Hi, my name is Dr. Elizabeth Ng. I am a pediatric neurologist with the Connecticut Children's Medical Center. And welcome to the Epilepsy Coalition 2024 Annual Epilepsy Conference. And I will be talking about the current management in epilepsy. So the main objectives of my talk is to understand the two major principles of action by which anti-seizure medications help inhibit seizure activity, know which ASMs can be used for focal epilepsy versus generalized epilepsy, and how do we determine what is the best seizure medication for our patients out of a list of potential seizure medications. So in order to decide which is the best ASM to choose, you have to understand the basic principles of seizure propagation. So there's either an increased neuronal excitation or a decreased neuronal inhibition. So if excitement is greater than inhibition, as you see in this cartoon, you have a seizure propagation. So there's a neurotransmitter called glutamate that's involved with increased excitation. So if there is increased glutamate release or too much glutamate, a seizure will be generated. And as opposed to, there's a neurotransmitter called GABA, which is involved with inhibition. So if there's a decreased GABA or too little GABA, a seizure will be generated. So anti-seizure medications act by one of two mechanisms in order to stop seizures, either enhancing GABA inhibition or reducing the excitatory glutamate transmission. So you see in this cartoon, these are the glutamate receptors that mediate excitatory synaptic transmission of glutamate, namely the voltage-gated sodium receptors, the voltage-gated calcium receptors, the potassium receptors, and also the synaptic vesicle glycoprotein 2A, which is involved that regulates the release and reuptake of the neurotransmitter glutamate. So you see here, these are the anti-seizure medications that work at the voltage-gated sodium receptor to decrease the transmission of glutamate, therefore decrease excitation, and to stop the seizure. These are the medications here listed that works at the voltage-gated calcium receptor, which works to decrease glutamate transmission and therefore decrease excitation and seizures. And here, the ezogabine works at the potassium receptor, but is now currently out of market. And these medications here work at the synaptic vesicle glycoprotein 2A, or SV2A, to decrease the release and reuptake of the neurotransmitter glutamate. So these are the presynaptic receptors. Now here are the postsynaptic receptors for the glutamate, glutamatergic synapse, namely NMDA, AMPA, and the voltage-gated calcium T receptors. So here's the anti-seizure medications that work at the NMDA receptors to decrease glutamate transmission. These are the medications that work at the AMPA receptors, and these are the medications that work at the voltage-gated T calcium receptors to decrease glutamate transmission to stop seizures. So at the GABAergic synapse or inhibitory, we have receptors, namely GABA T and GAT1, that's involved with GABA transmission or inhibition. And these are the medications here that work at the GABA T to increase GABA and therefore increase inhibition to stop seizures. And these are the medications that work at GAT1 to increase GABA transmission and therefore increase inhibition and stop seizures. At the postsynaptic membrane, we have the GABA A, which is involved with increasing GABA transmission. And these medications here, the benzodiazepines, phenobarbital, the pyramate, cenobamate, they work at the GABA A receptor to increase GABA transmission and therefore increase inhibition and stop seizures. So if monotherapy fails, you want to select a second anti-seizure medication with a different mechanism of action, and this is called rational polypharmacy. So these are the classic anti-seizure medications that were developed in the 1850s and the 1960s, like bromides, phenytonin, etosuximide, and phenobarbital. These are the anti-seizure medications that was developed in the 1970s, like clonazepam, valproic. These are the newer generation ASMs that was developed in the 1990s and the early 2000s, like felbamate, topiramate, ceniramide, lacosamide, rufinamide. And you see here in clobazam, and in 2016 is briracetam was developed, and 2018 CBD, and the newer ones is that was developed in the 2020, like cenobamate and fenfluramine, and you see ganalosolone developed in 2022. So with all these seizure medications, how do we know which seizure medication works best for our patients? So you want to take certain things in consideration, mainly the seizure type, the epilepsy syndrome, the side effect profile, the biological sex of the patient and the reproductive capabilities, also the comorbidities and the drug-to-drug interactions. So this is the classification of epilepsy by the ILAE. So they divided based on seizure types: focal, generalized, and unknown. The epilepsy types: focal, generalized, combined generalized, and focal, unknown, and the epilepsy syndromes. So there are comorbidities seen in different epilepsy types and epilepsy syndromes, and the etiology can be either structural, genetic, infectious, metabolic, immune, or unknown. So the ILAE updated the classification of seizure types in 2017 into focal onset, generalized onset, and unknown onset. So for focal onset, it can be either aware or impaired awareness, motor onset or non-motor onset, focal to bilateral tonic-clonic. For generalized onset, it can be motor, tonic-clonic, other motor, or non-motor, namely absence. And the unknown onset can be motor, which is tonic-clonic, other motor, non-motor, or unclassified. So focal onset seizures can be either focal aware, focal with impaired awareness, focal seizures evolving to generalized seizures, and the generalized seizures can be generalized tonic-clonic seizures, absence seizures, tonic seizures, atonic, or clonic seizures. So generalized seizures were previously called primary generalized, and this involves networks on both sides of the brain at the onset. And they're all presumed to affect a person's awareness or consciousness in some way. So no special terms are needed to describe awareness in generalized seizures, as opposed to focal seizures, which are previously called partial seizures. They start in the area or network of cells in one side of the brain. And describing focal seizures, we describe awareness. So either focal aware, if the awareness remains intact, even if the person is unable to talk or respond during a seizure, the seizure would be called a focal aware seizure. And this replaces the term simple partial. And focal impaired awareness is if the awareness is impaired or affected at any time during a seizure. So even if a person has a vague idea of what happened, the seizure will be called focal impaired awareness. So this replaces the term complex partial seizure. Unknown onset is if the onset of a seizure is not known. However, later on, the seizure type can be changed if the beginning of a person's seizures becomes clear. So focal to bilateral seizure was previously called secondary generalized seizure. So that's a seizure that starts in one side of the brain and spreads to both sides. And now the term generalized refers only to the start of a seizure. So now that we know the classifications, how do we choose the right drugs? So here we see we can decide on the best ASM based on the seizure type, either focal onset or generalized onset. So focal onset with preserved or impaired awareness, or focal to bilateral. And so these are the medications of choice for the focal onset seizures, like oscarbazepine, gabapentin. And for the generalized onset, we have tonic-clonic, tonic, myoclonic, atonic, and absence. So here you see the medications of choice like fenfluramine, clobazam, rufinamide, felbamate, CBD that can be used for generalized onset. And for absence, we can use etosuximide. And over here, these are anti-seizure medications that are broad spectrum because they can treat both focal onset and generalized onset. And that's namely Reproic, lamotrigine, topiramate, levetiracetam. And so medications that are FDA approved for all generalized epilepsies are Reproic acid, lamotrigine, levetiracetam, topiramate, perampanel, and locosamide. But ethosuximide is only used for absence epilepsy. So for childhood and juvenile absence epilepsy, ethosuximide and Reproic are the only ones approved by the FDA as first-line therapy for patients who only have absence. Lamotrigine, levetiracetam, and topiramate are approved as adjunctive treatments by FDA for patients who have generalized tonic-clonic and not just absence. So for juvenile myoclonic epilepsy and generalized tonic-clonic seizures, the FDA approved drugs are Reproic, lamotrigine, levetiracetam, and topiramate. So even though cinesamide is not FDA approved for primary generalized epilepsy, it's effective in treating generalized seizures. So medications that are appropriate to localization-related epilepsy are really any of the FDA-approved anti-seizure medications except for ethosuximide. So the FDA approved perampanel for primary generalized tonic-clonic seizures. As you can see here, the median seizure reduction was 76% for perampanel compared to 38% for the placebo. So the anti-seizure medications to be used for epileptic encephalopathies are clobazam, felbamate, rifidamide, CBD, fenfluramine, and serpentol. So it's very, very important to consider the biological sex of the patients because there are certain anti-seizure medications that can cause fetal malformation, like Reproic acid and phenobarbital. So you should really consider ideally not giving these medications to women in the reproductive age. So it's important to follow the pregnancy registry for updated results on major birth defects. So here are the listing of the pregnancy registry lists. There's a North American pregnancy registry at Mass General, United Kingdom and Ireland pregnancy registry, the European pregnancy registry called EURAP, and the Australian registry. So in considering a single ASM for a patient, it's very important to consider the comorbidities. So you can treat both the epilepsy and the comorbid condition, like migraines, mood disorder, increased weight, or neuropathy. So for migraines, we have Reproic, topiramate, and gabapentin that treats migraines. So if a patient has migraines and seizures, this will be ideal this will be a consideration because it's also anti-seizure medications. So if the patient's struggling with obesity, you may want to consider topiramate, cinesamide, and felbamate because they are both anti-seizure medications and medications to treat obesity. And for some of the affective disorders, Reproic and lamotrigine are good choices, and they're in addition also good anti-seizure medications. So it's important to also consider the drug interactions with other medications. So some of the older ASM can reduce the efficacy of the OCPs, like phenytonin and phenobarbital. And some of the newer ASMs can also reduce the OCP levels, like felbamate, oscarbazepine, rifidamide, and topiramate at higher therapeutic doses. And the oral contraceptives could also reduce some of the plasma levels of some of the ASMs, namely lamotrigine. So the oral contraceptive can reduce lamotrigine plasma levels. So if there is an individual that's on an OCP and also taking lamotrigine, it's important to adjust the dose of lamotrigine so they would not have breakthrough seizures. And there are newer pharmacological therapies available for children, namely cenobamate, fenfluramine, ganaxolone, and some of the rescue intranasal diazepam and midazolam. So cenobamate is currently approved, FDA approved for treatment of focal onset seizures in adults. It's not yet approved in children, but there's currently ongoing clinical trials to assess the potential side effects of cenobamate in children. They block the sodium receptors and they modulate the GABA A receptors. And studies have shown a significant reduction in seizures in children. There's been a greater than 50% reduction in seizures in 38 to 62% of the patients. And the most common side effects found was somnolence, fatigue, and psychiatric. Fenfluramine is FDA approved for Dravet syndrome and Lennox-Gastaut syndrome for individuals over the age of 2, and may also be effective in treating the CDKL5 deficiency disorder with a medium of 9% reduction in seizure frequency, and has also been used as an adjunctive therapy for sunflower syndrome. Brivaracetam has been approved by the FDA in 2016 for focal and generalized epilepsy. And it works on, it's highly selected, has a highly selective affinity for the synaptic vesicle glycoprotein 2A, SV2A that we saw earlier, which regulates the release and reuptake of the neurotransmitter glutamate, which allows a decrease in the neuronal excitability in the brain. And the main adverse effects of this medication is mainly drowsiness and irritability. So ganaloxolone is specifically used for patients with CDKL5 deficiency disorder, which is a rare neurodevelopmental and epileptic encephalopathy that's characterized by infantile onset epilepsy and severe developmental delays. And most individuals with CDD develop refractory epilepsy with multiple seizure types. And it's also effective in treating PCDH19 clustering epilepsy, which is caused by a mutation of the PCDH19 gene located on the X chromosome. And this is characterized by occurrence of treatment-resistant epileptic seizures, intellectual disability, autism, and behavior disorder. And about half of those taking this medication report a decrease in the seizure frequency of more than 50% within 28 days. And the main side effects that they've seen were drowsiness, mental confusion, excitement, and GI distress. And we also have 2 abortive intranasal seizure medications, namely midazolam nasal spray, which is brand name Nasolam, and diazepam nasal spray with the brand name Bertoco, which is the same medication used in a rectal form called Diastat. So when is a patient considered drug resistant? They're considered drug resistant if they fail at least 2 seizure medications to control the seizures at an appropriately chosen ASM and at the appropriate dose, or if they failed a rational polypharmacy, or the failure is not due to noncompliance. So you can see here, 63% of patients respond to ASM and remain seizure-free versus 36% are refractory. So what are the patient's chances of responding to 3 or more ASM? So the patient's chances of responding to the first ASM is 50%. To the second ASM is 11%, but it becomes significantly less with the third ASM. So about a total of 66% will respond to ASM, and 33% are intractable. So what do we have to offer to the 33% of patients that are intractable? So there are other treatment options, including neurostimulation, surgical resection, and diet therapy. So you can see here, for the resective surgery, we have temporal lobectomy. For the open loop stimulation, we have deep brain stimulation of the thalamus, vagus nerve stimulation. For the closed loop stimulation, we have responsive neurostimulation. And for the targeted ablation, we have LIT, or laser interstitial dermal therapy. So neurostimulation is the application of electricity to the central nervous system to reduce the seizure frequency and severity. It's either open loop or closed loop. So open loop is when you deliver a continuous stimulation in a predefined pattern without feedback. And that's the vagus, namely vagus nerve stimulator and the deep brain stimulator. The closed loop is when the stimulation is delivered only when the device detects a certain condition, and that's the responsive neurostimulation. So these are the available neurostimulation for epilepsy, namely VNS, RNS, Sante, which is also known as deep brain stimulation. So vagus nerve stimulator was FDA approved for intractable focal epilepsy in 1997. It's safe and effective. And it has also been well proven to help other different seizure types. The first human implant was in 1990 and is approved for individuals 4 years and older. And you can see a cuff is threaded around the left vagus nerve and then connected to the VNS generator, superficial to the pectoralis muscle. And then you have a magnet that swipes over the generator to activate the stimulation. So the vagus nerve stimulator is indicated for individuals with seizure onset zone that is generalized, or if they have greater than 2 epileptogenic foci. So studies have shown that a median of 51% of patients achieve a greater than 50% reduction in seizure frequency. In addition, the efficacy increases with time, and the quality of life improvement was 30 to 60%. And the common side effects are voice changes or hoarseness that's seen in 55%, coughing in 15%, dysphagia in 38%, neck pain in 15%. And seizures were reduced by more than 50% in approximately half the patients, and is effective in drug-resistant epilepsy and Lennox-Gastaut. So responsive neurostimulation, RNS, the stimulator is placed in the skull, and electrodes are implanted near the epileptic focus using depth or a subdural strips. The seizure pattern detector, IEEG, which is within the device, are programmed to trigger direct cortical stimulation when a seizure is detected. So this is a closed loop system. The RNS was approved by the FDA in 2013 for the treatment of focal drug-resistant epilepsy in adults. It is not presently FDA approved in children because of limited experience. However, some of the pediatric epilepsy centers are implanting RNS off-label, and those centers are familiar with the RNS use in adults, and it's designed to abort seizure activity. So the indication for RNS is in individuals with focal epilepsy, refractory to greater than 2 ASM, and they have greater than or equal to 3 seizures per month for greater than or equal to 3 months. And the seizure onset zone is in the Allegrein cortex or the language center. And also there's not more than 2 epileptogenic foci. So you can see here, there's a spontaneous seizure right here. Then the electrostimulation aborts that seizure, and that's what occurs with the RNS. And studies have shown that there's a 53% median seizure reduction in 2 years after implantation, but a 66% reduction by 6 years. So the responder rate improves over time. And in the pediatric patients, studies have shown a greater than 80% reduction in seizure frequency. And RNS is generally well tolerated. You can see risk of infection in about 4%, intracranial hemorrhage about 5%, and lead damage in about 3%. So we also have deep brain stimulation, DBS, and this was FDA approved for use in intractable epilepsy in patients 18 years of age and older in 2018. So you have a permanent generator implanted superficial to the pectoralis muscle. Then the electrodes are placed in the bilateral anterior nucleus of the thalamus. So the anterior nucleus of the thalamus is seen as a relay station that amplifies and synchronizes discharges from the hippocampus and the posterior thalamus. So by stimulating the anterior nucleus of the thalamus, you can abort the seizures. And 69% there's a 69% median seizure frequency reduction after 5 years in adults. And it's FDA approved to treat, again, intractable epilepsy in adults that has greater than or equal to 6 seizures per month, or is refractory to greater than or equal to 2 ASM. The data is lacking, however, in the pediatrics, but several case reports show that it's promising because of its tolerability and its efficacy. And there's a median percent seizure reduction from baseline at 1 year was 41% and 69% at 5 years. So deep brain, so case studies have shown that in DBS in children, there's a greater than 50% seizure reduction. And the Santé trial found that the common adverse effects were implant site pain and paresthesias, infection and lead misplacement, depression, and memory impairment. So here's a summary of the FDA-approved invasive stimulation approaches. So here we see the VNS, which is open loop, pre-programmed, extracranial. The main side effects are usually local infection, hoarseness, vocal cord paralysis, and the seizure reduction at 1 year was 26%, and at 5 years was 56%. For RNS, it's closed loop, it's responsive stimulation, it's intracranial, and the main side effects are infection and intracranial hemorrhage. And you see the seizure reduction at 1 year was 44%, and at 2 years was 53%. And for DBS, it's open loop, it's pre-programmed like VNS, but it's intracranial, and the main side effects are infection, intracranial hemorrhage, and you see the seizure reduction from baseline at 1 year was 41%, and at 5 years was 69%. We also have dietary therapies for refractory epilepsy. We have the ketogenic diet, where there's a 4-to-1 or 3-to-1 fat to protein and carbohydrates. We have the medium chain triglyceride diet, which is 1.2 fat to 1 protein and carbohydrates. We have the modified Atkins diet, which is 0.9 to 1, and the low glycemic index diet. So the dietary treatment is indicated for any type of epilepsy. The ketogenic diet is a treatment of choice for certain epileptic encephalopathies like GLUT1 deficiency and myoclonic astatic epilepsy. But the diet is contraindicated in any patients with fatty acid transport problems. So after 6 months, there was a 50 to 60% of the children had a greater than 50% reduction in their seizures. So if the neurostimulation and the dietary therapies do not work or fail, we have surgical options. We have resective surgery, we have LIT, which is laser interstitial dermal therapy, we have multiple subpile transection, MST, corpus callosotomy, and hemispherectomy. So resective surgery has the best long-term surgical outcome and best prognosis in individuals that have mesial temporal sclerosis. There's an 82% seizure freedom in 12 months, 76% at 24 months, and 64% at 63 months. So better seizure outcome equals a significantly better long-term quality of life. So for extratemporal resection, there's a 25% to 50% seizure freedom. It's most favorable if the outcomes are seen in the occipital parietal region rather than the frontal region, and the better prognosis if the anatomical lesion was identified. So laser interstitial dermal therapy is an MRI-guided laser technology for dermal ablation. It was approved by the FDA in 2010. And this is where laser energy is delivered to the targeted area using a laser applicator, as you see here. As light is delivered through the laser applicator, temperature in the target area begins to rise, destroying the unwanted tissue. The entire procedure is viewed in real time on MR images that shows the dermal maps displaying the distribution of the heat to ensure safety and successful target treatments. So the advantages of the LIT over resective surgery is it's less invasive, there's a shorter procedural time, and a shorter hospital stay. And there's a 30% complete seizure freedom with the LIT, and 67 in patients with MTS, there's a 67% seizure freedom. So multiple subpile transection, or MST, is typically indicated for if the epileptogenic zone is in the dominant eloquent cortex. So this is a disconnection type of procedure that will to avoid resecting the eloquent structure, again, which eloquent zone is a language zone. So about 38% of patients were seizure-free at the 2-year follow-up, And there was 95% reduction of seizures in 87% of patients that had generalized seizures and 68% that had focal seizures. So corpus callosotomy is a surgical division of the corpus callosum. It's either partial anterior, partial posterior, or complete. And the aim is to arrest the propagation of the epileptogenic discharges from one hemisphere to the other. So they found that individuals, like 88% of those who got total corpus callosotomy, had a worthwhile reduction in seizures versus 58 or 59% of patients who underwent interior corpus. So the total ones did better than the ones that had interior corpus callosotomy. And the seizure type that responded the best to it was the drop attacks. So hemispherectomy is either anatomical or functional. So anatomical hemispherectomy is when it's a removal of the frontal, temporal, parietal, and the occipital lobe, and you preserve the thalamus and the basal ganglia. Functional is when you have a disconnection of the lobes with minimum resection. And the seizure freedom ranges from 52 to 80%. And the common complications was hydrocephalus, fever, subdural epidural hematomas, and superficial hemosiderosis. So in conclusion, it's important to classify seizure type before choosing the appropriate ASM. And when choosing a second seizure medication, you want to apply rational polypharmacy. And you want to choose an ASM with another mechanism of action. And you also want to consider other variables when you choose the ASM, like the sex of the patient and the medical comorbidities. So I want to thank the Epilepsy Coalition of New York State and the Epilepsy Foundation of Northeastern New York for allowing me to speak and present during the National Epilepsy Awareness Month, which is in November. And I also want to give special thanks to Dr. Rebecca Spiegel for giving me permission to use some of her slides. So we look forward to seeing you at our live Q&A on November 16th.